All right. So thank you guys so much for joining us. Today we're going to talk about medical cannabis, and it's an interesting presentation with there's two sides to every coin. And we hope to kind of give an unbiased look. Of the three speakers, we have no financial disclosures related to the cannabis industry, but I can say they throw a lot of money at a lot of people. My husband doesn't want to hear about the offers I have to turn down anymore. But cannabis has its disclosures too. So first and foremost, cannabis is not FDA approved for any condition. So when we talk about medical opportunities or concerns, it's important to realize that, again, the FDA has not evaluated it for safety, and the DEA says it's federally illegal, no acceptable medical use, and a high potential for abuse. There is cannabis research through the U.S. government, but it requires triple agency approval, which is definitely a barrier to widespread use. We have objectives for the day, and we're going to take you through a little bit of a story, starting with the role of cannabis and endocannabinoid system in the body, and then going on to other considerations of a bigger scope of our patients, especially considering behavioral health, and then we'll talk about policy. So first and foremost, so we said the government says cannabis has no medical use and a high potential for abuse, but the U.S. government actually has been growing cannabis for, at this point, over 40 years through the University of Mississippi, and they've been actually shipping and dispensing it to patients. Our government allowed for a limited investigational new drug application around cannabis, and 13 patients were able to get into the program. One specifically was a patient who had chronic pain related to their medical conditions, who testified in front of the DEA that using cannabis allowed him to decrease and ultimately stop using Dilaudid. And he's still getting 300 marijuana cigarettes every single month from the U.S. government, compliments of your tax dollars. Further, the U.S. government also owns a patent on the use of cannabinoids for various neurologic conditions, and has had this patent since the 1990s. So I use the term medical cannabis, and I think that's important because as a pharmacist, for me, medication has to have a repeatable effect. If I give someone blood pressure medication today, and then I give it to them tomorrow, I want a consistent response. And we need the same thing with cannabis. If it's a medicine, it needs to be properly labeled, assayed, and we should have more predictable response from it, and make sure that it's safe. Levels of mold and yeast that are controlled, and also pesticides and contaminants. Contaminants from how it's grown and how it's processed. Some of the illicit chemicals that are used on these products, especially pesticides, can actually break down to things like cyanide gas, which is no good. And the extraction process can actually concentrate some of these pesticides. So medicine should be managed as medicine. So let's talk about the brain, because that's what's super exciting to me. In school, we learn about neurotransmitters. So our neurons are constantly talking to each other, firing and sending messages. And in school, we learn that one neuron tells another neuron what to do. So when we look, we have this first neuron, and it's the presynaptic neuron, and it makes chemicals, neurotransmitters. And they're like little proteins. And this neuron's making neurotransmitters all day long and putting them into water balloons. And when the moment is right, it sends the neurotransmitters across the cleft to bind to a receptor and do something. So there's a lot of neurotransmitters. There's things like adrenaline, right, that tells your body to get excited. There are things like GABA, which is an inhibitory signal. It tells the body to get quiet, right? It's similar to how alcohol works, or benzodiazepines. There's also glutamate's a neurotransmitter. Too much glutamate is excitatory. It's related to things like chronic pain, and it's also related to some of the negative things we see in our patients when they go through alcohol withdrawal. So these are the chemicals, and this is how they work in this one direction. But we learned now that there's another system. It's called the endocannabinoid system, and it works in the opposite direction. When this neuron has had too much signaling and it wants to tell the other guy, hey, turn off the faucet, please, it's too much for me, they'll synthesize a chemical, but it's different. This chemical is an endocannabinoid, and it's a fat molecule, and it's only synthesized on demand, and then it's set retrograde across the synaptic cleft to bind and to stabilize the water balloons and not release any more chemicals. So I like to think about it this way. I have two boys. I have a big 17-year-old and a smaller 13-year-old. And I equate it to my 17-year-old filling up a whole bin full of water balloons and going up to his brother and said, hey, want to have a water balloon fight? And the kid's like, yeah, and gets tossed an empty bag of water balloons that aren't filled up yet. So imagine if somebody's throwing water balloons at you, telling you to do something, but yet you have to fill one up, throw it, fill one up, throw it. So you can think about the system. There's a yin and yang to the system. So the endocannabinoid system does modulate the release of neurotransmitters, but not to as powerful of an effect. And what's interesting is, in your brain, the receptor where the neurotransmitters bind are very specific. So there's a neuron that just makes dopamine. There's a neuron that just makes serotonin. And they have to bind to the right lock and key. But the endocannabinoids are universal, and they can bind on all these different receptors, decreasing the release of neurotransmitters. So if you take all the receptors combined where serotonin, dopamine, norepinephrine all bind, there's still more endocannabinoid receptors than all the other ones combined, which is a pretty powerful system in our body. If you look at the brain, so this is just a color radiograph, and the warmer colors show the higher concentration of endocannabinoids. But they're pretty much everywhere in our brain in relatively higher concentrations, except in the brainstem. And that's important because no amount of signaling of the endocannabinoid system has ever been known to affect respiratory rate, so breathing, and thus death. And you can't say that about things like too much alcohol, you stop breathing and die. Too many opioids, too many benzos. So in this case, cannabis is different from those other chemicals, as are endocannabinoids. And you'll find the endocannabinoid receptors in many other places in the body. We think about our sympathetic nervous system, so that's that fight or flight response, and that's where adrenaline works. But then also you have this other nervous system, the parasympathetic nervous system, that is more sleep, rest, digest. And endocannabinoid system is actually heavily integrated into some of those signalings, as well as the sensitization of pain. So we have morphine, for example, binds at a receptor, and endocannabinoid binding can actually have cross-reactivity and help with that pain modulation, amongst other things that it does. And then there are also endocannabinoid receptors all throughout our body. It's a different type, so there's two forms of the receptor, but much the way the endocannabinoids work in the brain, it's very similar to the way they work with immune cells. So white blood cells will stimulate each other by releasing chemicals and signaling, hey, get excited, go attack something, you know, it's time to get it all inflamed. And so endocannabinoid signaling will actually decrease white blood cell stimulation. Normally white blood cells will be like, hey, they'll send out a chemical marker and tell all their friends to come. And endocannabinoids will actually decrease the migration of other white blood cells into the area. And they upregulate during periods of inflammation. So it's very interesting the way the system works, and it really is the yin to the yang of many of our mechanisms in our body. So now let's look in on the brain a little bit closer. So we see the receptor, and we see something binding it. We think about a lock and a key. But it's a little bit more complicated than that, because sometimes there's a lock and a key, but sometimes the chemical wants to touch that receptor other than in the lock. So we'll talk about that. So first is THC. It's the molecule that gets most of the attention. It is a pain-relieving molecule in and of itself and muscle relaxation. It affects nausea, vomiting both in the intestines as well as in the brain, and it helps people sleep. I think of it as it turns on the light switch. It activates, turns on the radio. But THC has a lot of biphasic effects. So at low doses, people talk about it helping relax their anxiety and controlling nausea and vomiting. But at high doses, It definitely precipitates anxiety and even causes psychosis. At high doses, patients can get this hyperemesis syndrome. It's a cyclical vomiting syndrome. And the treatment is stop ingesting cannabis. And then there are definitely cognitive effects, and we'll talk a little bit about them at the end: memory impairment, weakness, and falls. But I think the duality of the molecule is really important. Low doses versus super high doses, and how do you control a dose and make something consistent, which is important in the patient population that we're talking about today. Cannabidiol is another molecule, so they're both present in the plant, some in different amounts. So if THC turns on the stereo, I would say CBD is the volume or the bass. It changes the quality of the music, but it in and of itself is not going to turn on the system. So CBD has different effects. Alone, it is known to modulate the immune system. It affects seizures in patients, and that's why it's approved in pediatric patients. And it can also enhance the endocannabinoid activity of the other chemicals that are in our brain. So lots of excitement around it, and I know Dr. Lake will talk about some data relating to cravings and in use disorders. But like any chemical, side effects include diarrhea, headache, and drug interactions. There are some adverse effects, and we'll go through them as we hit those topics. But I like to remind people that every medication has side effects and should be noted with regards to patients, and everything is a risk versus benefit assessment in each patient population. There are drug interactions, so THC increases your heart rate, and it is stimulating, so patients who take it concurrently with things like amphetamines could potentiate cardiac issues. Though alone, it's not going to increase respiratory suppression, it will potentiate other CNS depressants, so alcohol, opioids, muscle relaxants. So in and of itself, it has similar pain relieving, some pain relieving effects and muscle relaxation, but it's additive, and you have to be thoughtful with what patients take. I mentioned heart attacks. This is important. I find a lot of patients who are in their 60s and they have diabetes and they want to take cannabis for pains in their fingertips, but they've had a heart attack before. This is not the best drug. After you smoke it, it can increase your risk of heart attack, and in those who have a history of heart attack, it will increase risk of death. So something to consider, especially in patients who've abused amphetamines or other medications that affect the circulatory system, such as cocaine, methamphetamines. Also, psychosis. It is a known side effect of the drug. It can be precipitated, and it is really a dose-response issue that must be considered. And nowadays, cannabis products are more concentrated than they have ever been. Comparison-wise, in the 1970s, the cannabis had 2 to 4% THC. Some of these products now have 30% THC. We have extracts that are 90% THC, so it makes it difficult for people to modulate, thus increasing the incidence of these adverse effects. It is recommended by national organizations against cannabis use in pregnancy. I think that if you get some really knowledgeable people, you can have a great debate on this topic, as the information about increased adverse effects in the offspring of women who chronically use cannabis during pregnancy is fraught with confounders. Mothers who also, were cigarette smokers, drank alcohol, and there was a lot of socioeconomic issues that affect the data. But I'm a very conservative person, so I would recommend against that unless there was a critical health condition in the pregnant patient. So in that plant, there's a whole lot of chemicals. We think about THC and CBD, but there's also other things. CBN is a breakdown product of THC, and it's very sedating. It's desirable for products for sleep, and it's the only other molecule in the plant that is psychoactive. But there's a lot of other things, and maybe it doesn't relate to this topic, but things for cardiology, for everything from diabetes. What also is important is the other chemicals that are not cannabinoids, such as terpenes. So think about aromatherapy. It definitely has value. It was major medicine for hundreds of years. And one of those chemicals is linalool. It comes from lavender. So I'm from New York City. We grew up in my grandmother's house. Her bedroom was across an alleyway from a very large hospital emergency room, so ambulances all night. We moved to the suburbs, and she said, Christine, I can't sleep. It's too quiet. It's awful. And she said, we need to go out and find some lavender and dry it and put it in pillows and put it under our bed, under our pillows. And I was surprised, but what did she know? She knew that that chemical actually affects the stimulatory and inhibitory chemicals in our brain and helps relax people. There's high concentrations in certain strains of cannabis, so it can be helpful for patients for anxiolytic activity. But the big thing is it has to be a standard product. We're not talking illicit products that you don't know what it is. It was in somebody's pocket. How old is it? What might it be contaminated with, intentionally or unintentionally? So these products are grown in facilities where they have seed-to-sale tracking across all aspects of it. What is desired is the flowering top of the female plant, which produces the medicine. And they make extracts. And the extracts are from the dried flower, and there's a couple different ways. They can make extracts with chemicals like butane, so hydrocarbons, which are important to think about because they'll extract the chemicals, but you need to get rid of, they extract the cannabinoids, but you've got to get rid of the chemical residues. They also use things like carbon dioxide to extract the medicine. They're very sophisticated, and also you're creating products that are more concentrated than we've ever had before. There's even companies that are purifying different cannabinoids for use as injectables, which is still very early in research, but it lets you know where things are going. So your patients may, they don't have to think about inhaling products. It may be low-dose oral products as well. There are other opportunities. One thing that's difficult is, what's best, hemp or cannabis? Well, it's important to know that hemp is cannabis. Hemp is just a different strain of cannabis sativa that meets the legal definition of having a low amount of THC, less than or equal to 0.03%. But it still is the same drug. And what's interesting is if you look over here at this diagram, they looked at different strains of cannabis. So people think about sativa as a stimulating strain. They'll think about, hybrids as having sometimes both of those effects. Indica, more of an indicouch, so sedating a body high. And then there's hemp. But when this researcher looked at DNA from all different strains of cannabis and hemp throughout the country, they found that the indica and hybrids and sativas were pretty much all the same. They didn't have clear genetic separation. And what's interesting is the hemp that's grown in the U.S. and the cannabis that's grown by our federal government are actually more similar. So U.S. government cannabis, which they've been doing all the research on, is equivalent to modern day hemp for the most part. So when you look genetically, these are the two NIDA samples, and then this is the whole hemp sample. So it's interesting that whenever you're looking at research, you need to consider the source of the cannabis because what's being studied is not the same as what's available in the retail market for both adult use and for medical use. And also, what's the difference? I get lots of questions, what's the best strain of cannabis for my multiple sclerosis or my breast cancer? And I hate those questions because my answer is I need to look at the chemical analysis of that product to see what cannabinoid profile and what terpene profile is really in it. This is the same author, and what she did was she compared the genetics of all these different strains of cannabis. So she found sour diesel, for example, at 15 different dispensaries across 20 different states. And she compared them, and if you look, you would expect that if the strains were all the same, there'd be a cohort of one strain here, one strain here. But the colors are all mismatched, and it basically shows that there was no consistency among strain name at all. So you really can't look to a strain of cannabis to really understand its therapeutic potential. Unfortunately, you have to look at what's in that individual product, and that's why you need the profiles and good labeling. Most products are sold as a ratio of THC to CBD. And again, THC-dominant products are much heavier psychoactive effect, whereas CBD-dominant or CBD-only does not have psychoactive effects. Some people will say when they have CBD, they do feel a little stimulated, So we recommend starting it in the morning rather than in the evening. But you can see, unfortunately, in the U.S., the high THC is desired, so our strains have been selectively grown to show more THC, and that affects the profile. So where to get information? Certainly in an hour and a half, we can't tell, or 2 hours, we can't tell you all those things, but this is a great document. It's available for free from Health Canada, and it talks about cannabinoids. It's 400 pages. I like to download documents, and then I'll control F them with a keyword. I will be honest with you, I control F documents all night long to learn. I suggest you find some good words in that one. Here's another document that's great. Actually, the other document's great. This document's good. This document is something that was put together where they got thought leaders in different areas of science to review the literature and then provide a summary based on where is their evidence. This is dated now. This is 2017, whereas Health Canada did 2 publications, which is nice. So for the National Academy of Science, what they did is, where's the data? So we know it helps with chronic pain, not acute, but chronic. It'll help with chemotherapy-induced nausea and vomiting, can help with symptoms of MS and short-term sleep outcomes. So they do have beneficial data, but also there are side effects. When you burn a plant, when you burn material and inhale it, you can have respiratory symptoms. Cannabis does affect cognitive function and increased risk of motor vehicle crashes. However, there's a lot of conflicting information around impairment and driving, but this study showed an increase in risk. There's a study that supports low birth weight in babies, and then there's an association with schizophrenia and cannabis. And there's a great scientist, Dr. Cobb Scott, and who has published a couple papers on this. But the question is, what comes first, the chicken or the egg? So development of schizophrenia has an association with adolescents who ingest high amounts of cannabis. So things have posed, is it the high frequency of cannabis in adolescents that increases your chance? Or might it be that in a young age they're experiencing symptoms of schizophrenia and they don't know it, they don't understand it, and they're self-medicating with cannabis to try and manage those symptoms, those voices, those feelings. So it's not clear, but the cannabis use may be a function of symptoms of the disease. And then also some data with less evidence associated with it, which includes PTSD and anxiety. So with this, I want to hand it over to Dr. Lake, because I think the important thing to realize is doctors do not prescribe medical marijuana. They can recommend medical marijuana, but ultimately, a physician cannot tell a patient to ingest a controlled substance. It's not something that they're able to do. But by law, doctors are allowed to tell patients about all options that would be available to help them. They have a right to say to patients, hey, I think this might be able to help with your symptoms. Let me make a recommendation for you. So I think that's really kind of critical perspective. And we'll talk later in the program about considerations for allowing patients to access medical cannabis. Dr. Lake, I should have handed the screen over to you to be able to show content.
All right. Can you see me now?
Yes.
All right. Thank you for that. So when we talk about addiction in cannabis, it is something that on daily regular users, we do see this happen in about 1 in 10 users may meet the criteria for cannabis use disorder. And we do have a withdrawal syndrome that's pretty well established at this point. It's not something that's as severe as alcohol or benzodiazepine withdrawal, but certainly it's something that with the disruption in sleep, the increase in anxiety, the bizarre dreams, it's something that certainly could push somebody over the brink. If you think that they're, say, somebody's medicating with this in a situation like managing their PTSD, and then they're thrown in a situation where they don't have access to this, those withdrawal symptoms can certainly aggravate other underlying conditions. And while it might not be dangerous in the same way as kind of precipitating seizures, it certainly can have some negative consequences in and of itself. So before I go too far with this, I like to discuss the difference between use and use disorder. Now, I realize that I'm talking with an audience that has a lot of people working in the mental health and addiction fields, but I do want to make sure that I bring this up. So dependence, this is the relationship that a lot of us have with coffee. If we don't have it in the morning, we're going to feel kind of grumpy, maybe feel squinty-eyed and have a headache for another additional hour. But you're not going to be stealing from anybody to try to get that hot cup of joe. You're not going to call off of work and leave friends and kind of do other destructive things in your life simply to get more coffee in your life. Now, that dependence is physiologic, and it may be an anticipated part of certain therapies. For example, beta blockers or SSRIs, these are common medications that we use, and there's a withdrawal syndrome for them too. With chronic opioid therapy or chronic benzodiazepine therapy, those are things that we consider as well. But that does not necessarily equate to addiction. Addiction's that dysfunction around the substance or the action and the outsized role that it has in life. And I just need to make sure that we're bringing that up before we get too far here. Now, how do we get to that place of addiction or a use disorder? Well, a lot of times it comes down to this motivation. At first, it can be a positive stimuli at first, maybe getting some pleasure or euphoria or simply relief from chronic stress. And there's repeated reinforcement with ongoing use. However, over time, a lot of times there's some tolerance and physical dependence, and this starts to become, the good part is just when you simply don't have the withdrawal again, and that negative reinforcement tends to drive continued use here. Now, if you can use maintenance therapy, so a lot of times in opioid use disorder, we're using maintenance therapy here to keep somebody out of that withdrawal cycle, but sometimes also limiting euphoria, which is something that may or may not be a perceived benefit. So I have this ambitious goal here of trying to go from our brain physiology the whole way up to pharmacology and decisions that we make around access to medications and access to certain forms of this and what this does to treatment. So in this first phase, when we're getting a euphoric or pleasurable response, it depends on having effective absorption. If you don't actually know how to inhale, because you're not used to inhaling anything, it's probably not going to work very well. You're not going to think it does anything to you. It's got to be an effective dose. It can't be something that's small and didn't really do anything. And it should be a clear effect. And more so if there's a rapid effect, then it's much easier for us to connect in terms of how we as humans make memories and form our patterns of how we do things. There should also be a positive response, and this can be biological, it can be psychological, it can be social, just being able to be with other people and be accepted and to enjoy that. That's something that is underestimated when we talk about substances and their effects on us. So breaking into the physiology here. So step one, opioids get in the brain. These can be direct or indirect. So with THC, it does end up having some mu agonism. This is something that we can see in mouse models that the reward effects, which can kind of build up adverse behaviors, and some of the pain-relieving properties actually happen through some of the opioid receptors. So this is similar for cannabis as well as opioids, but primarily this is something that we're seeing through the opioid lens when I'm talking about this physiology. Now, when there's mu agonism, so when these receptors get hit, these opioid receptors get hit in the VTA or ventral tegmental area, it decreases the amount of GABA tone. So there's constant signals of all these neurochemicals constantly going through our brain. There's not a time when it really just stops and shuts off. There's never a blank slate period or then, oh, something happens, like in some sort of sterile lab environment. We're constantly experiencing things all the time. And there's always some level of stress. It can be kind of a low level, it can be a high level, but there's never a zero level or we pass out and we don't have any blood pressure. It's important. So when we have that GABA tone, there's a set point, and chronic stress will have this chronically set pretty high. Now, if you do something and it decreases that stress level, that GABA tone level to the nucleus accumbens in the mesolimbic system, which actually controls a lot of our feelings and kind of how we emotionally process things, when the stress level goes down, we actually get more dopamine release. So the dopamine, while we sometimes think about this as a pleasure chemical, it's much more complex than that, and it's actually much more a learning chemical. Every time we learn something, we are dependent on dopamine. Now, because we're constantly experiencing things, there's always some dopamine coming into it, to different parts of our brain. Now, if all of a sudden there's a bunch more, and it's this fast, steep release of dopamine, guess what? We're going to remember that, and that's what's called salience. Something happened, and it's a salient memory. It's something that we're going to really remember. And it activates two different types of receptors in our brain. The first is the D2, which is high affinity. It's actually going to bind to all the dopamine first. So all the dopamine rushes in, and then it's actually going to hit these first. So a little bit of dopamine coming in, it's just going to get hit by these D2 receptors. It's going to all stick to there, and we're not really going to remember it. Why? Because it was probably not important. It's the mundane rerun. It's your general commute to work every single day. There's no reason why you need to remember that because it's constantly happening. It's nothing new. But if it's new, there's more dopamine. And guess what? Those low affinity receptors that usually don't get much dopamine, now they get stimulated. And what that does is it increases that salience of that temporally correlated memory. So everything happening at that time gets high priority in our brain. And this is how we associate people, places, and things with drugs, with experiences, with things that are important. Lots of those different aspects all get mushed together because we remember what happens when something was really good or really relaxing or really salient, really something that is worth remembering. So that's a key part of this physiology. So and salience, that can be increased by chronic stress. So there's kind of a bigger drop in that GABA tone initially, and we get more stress relief. If you're already pretty cool, you feel fine, and then you take something that reduces it, it's not going to have as big of an effect. But if you're chronically stressed out and need some release from that, guess what? That's going to have a lot more important of an effect. And if that effect is faster and stronger, then we're going to have even more salience. That's going to be easier to remember. So we can actually test this. And let's say you got a new chemical that's going to be a new cholesterol medicine. You also want to make sure that it's not actually something that's going to become a problem in terms of people developing unhealthy relationships with it and use disorders. So we got to test it in something, and usually it's rats. And you get two buttons, the food button and the drug X button. And sometimes there's some saccharin in there because maybe it tastes bad, maybe it's mixed with food. There's different ways you can do this. But it's usually a rat alone in a cage with electrodes in its brain or somehow connected to a machine. That's pretty terrifying. You're literally a rat alone in a cage. And guess what? If they're stressed out and something reduces that stress, it's going to be remembered. That rat's going to be a setup for a use disorder, really. But what if we had a happy little rat park where they could run around with their little rat friends and have little rat fun, and they could imagine the little rat babies playing together in the future, and we gave them unlimited access to morphine? Well, guess what happened? Then they tried it out, but really they wanted to play with the rat friends, and that's what they did, and they didn't really use that much morphine. So we saw that actually there's a stress model that we can see in rats too. So we see this in humans, and when we look at population-wide risk factors for developing use disorders and addictions, we see this when there's kind of trouble when an individual kind of regulating their own behavior and there's aggressive behavior, there's not really any external support for that. So the parental supervision's not there. There's not the social skills, so they can't connect with peers. There's easy access to drugs and drug experimentation, so they can easily access that. And they're kind of scared of their neighborhood. It's not safe to go out. There's poverty. These are things that can increase your risk for addiction. The opposite things also seem to decrease your risk of use disorder as well. Good self-control, parental monitoring and support, positive relationships. You like school. It's not something that's scary, and it's not something that you don't like. There's not easy access to drugs, and you don't mind your neighborhood. You kind of like it. You're proud of your neighborhood. Those are things that matter when it comes to humans and our risk of addictions. So what's the clinical correlation? If there's chronic stress, that's going to increase that risk of an addictive potential for any substance. So not just something specific, but if we're worried about a substance, we should also worry about what's that chronic stress. And guess what? Drug access can be very stressful. So illicit markets can potentially reduce harms here, and that's stress. So if you have an unregulated market, you have law enforcement-related consequences. These are things that can potentially increase the stress of accessing drugs and can therefore increase that chronic stress, thus continuing the same reinforcing cycle. Next thing is potency. So thinking about alcohol. Alcohol has been around for millennia, and it's a key part of many cultures. And this is something where they might talk about drunkenness, but there wasn't necessarily this discussion about alcoholism until we started making distilled spirits. And this is something that once we started raising the alcohol content significantly, now we're talking about alcoholism, at least in Eastern European cultures. Now, if we talk about opioids, these are opioid poppies here from something that's pretty darn ancient, 1500 BC. It goes way back because whoever made tea out of this thing first realized that their pain was finally gone, and that's a big deal, and you're going to remember that. And so it's part of a lot of medicinal manuscripts through as far back as we can go. Now, if we take that poppy and we start extracting those opiates, and then we figure out that, hey, we can synthesize opioids, which are things that hit that same receptor, and we can make them more and more and more potent so that you can end up taking higher and higher doses, guess what? We're having more and more discussions about risk, not only just because there's a hypodermic needle at this point, but also because we're having more and more potent forms of it, and it's a different conversation than what they were having back in 1000 BC about opioid problems. Now, let's look at what's happening with cannabis. It's very hard to find an old manuscript that's talking about medicinal herbs that is not mentioning cannabis. It's featured in virtually all of them that I'm aware of, unless that culture didn't have access to cannabis. So this is something that is highlighted in a lot of medicinal manuscripts. It goes way back. Now, fast forward to today, we've got lots of hybridized strains, much higher amounts of THC in the dried leaf than we ever had before, and now we have synthetic cannabinoids. And these are ones that have continued to get much stronger. So if we look at the EC50, this is what's the concentration of this chemical in whatever liquid to saturate half of the receptors in a given area. For THC, it's 171 nanomoles per liter. It's a pretty small amount, actually. It's a pretty strong chemical, but 171. Now down to 1.9, so you can have almost 1/100th, so 100 times less of some of these chemicals, and you're getting that same effect. So it's 100 times stronger, and that means that you can take in a whole lot more of this at a much faster rate, and it's something that we don't really know what's going to happen if somebody's using this long term, but I anticipate it's going to have different effects. Now, the next part in terms of memory creation is temporal correlation. So how soon did something happen after, or how soon did you get a response after something happened? So when did B happen in relation to A? Well, if you touch a stove, then guess what? It's going to hurt. We're going to remember that. That's something that kicks in pretty fast that we remember that. Now, what if I touched a weird leaf 2 days ago, and now there's a rash? Well, how do you figure out it was that leaf? You probably touched lots of leaves over that time. Maybe you changed your soap or deodorant or something else changed, and you have this weird rash, and you're racking your brain, and you can't figure it out. It's pretty common that we're racking our brains trying to figure this out. Nobody's generally trying to figure out how their finger got burned. You generally know how that happened. Same thing goes for positive reinforcement. Now, I'm not going to put pictures of people using drugs up here, but if you consider sugar a drug, then this pixie stick here is going to get absorbed much faster. Potentially there's some sublingual administration here going on, but you have the same amount of carbohydrates in this whole wheat loaf of bread here, but it's delayed. And guess which one kids are going to go after? It's not the whole grain bread unless your kids are really into it. So clinical correlation here, the pharmacology of the form and the means of administration can probably impact use disorder risk. So there's higher risk with higher potency, and we can ingest much higher functional doses much more rapidly, either intentionally or not, if you have a high potency product. Also, if there's a rapid onset of action, maybe it's insufflated, so snorted through the nose, smoked, it's going absorbed through your lungs, or injected through your veins, those are things that are going to be much more rapidly absorbed than something that's a time-release oral formulation, a patch that's continuously releasing it, or a topical formulation. There are some means that are intentionally slow release. A lot of our medications, we try to get to once a day so that we don't have to deal with this constant up and down of medications. So one would expect less use disorder risk with a lower potency, slower onset product. Just kind of going from that basic sort of pharmacology to thinking about the practical aspects of it. So now we go into the second phase where there's early repeated use. We're maybe not in the withdrawal phase here, but there's secondary memory processing. So is this the same experience that I've already had, or is it not the same? So if it's the same, then we start kind of pruning these memories so that we can kind of anticipate what's going to happen, and that the brain starts to create these circuits throughout our brain. And what really kind of builds consistent salience of that memory over time, additional layers of that paint, is if it's phasic. So it means that it comes and it goes. It comes and it goes. If it isn't something that's new again, you're just kind of this chronic, steady, high dopamine receptor thing, and you're going to start ignoring some stimuli. Now, if something different happens, like there's this adorable lizard creature that showed up on your screen called a pangolin, you might remember that. And if you don't remember anything else, it's that novel experiences are going to be remembered a lot more instead of just another PowerPoint slide. Hopefully you'll remember the pangolin tomorrow. So if you have a constant steady stream, say the air in the room that you're in, you're not feeling that anymore. You're not paying attention to the temperature of the room. Thank goodness, because now your brain can see the little pangolin here again. But what you can do is you can focus on what you're doing instead of kind of all the stimuli in the whole world, and that's important. So this phasic dopamine is on and off is something that helps build that into your brain. Now, regular cueings of the environmental situation and what the feeling is, that's going to, again, kind of start to automate behavior, kind of where you are, you're going to go into a certain mode. Who you're with, a certain mode. So people, places, and things, that's going to actually start generating automatic behavior in ways that's kind of already built into our brain. We're just going to go on autopilot, and that's something that we actually see in these striatal-globus pallidothalamicortical loops, which that's a mouthful, but that's a lot of different parts of our brain, and there's a big circuit that starts to really get honed in when we have these repeated experiences. Now, if you have random pairing of cues, then you get irrational behavior. So randomly paired stimuli leads to randomly paired behavior. So if something's variable in the quality, hard to access, you don't know when you're going to have the next access to this experience, or how potent it's going to be, that's going to mess with you. And here's Exhibit A. If you think that rubbing somebody's head is going to help your NFL team score that field goal, that has nothing to do with it, but people do it all the time. If you know any crazy sports fans, they do things that make no sense. And you know what? The fact, whatever you did watching the game has nothing to do with how well your team did, but people keep doing it. You know why? Because it's randomly reinforced. Whatever you did had nothing to do with that running back making the big run or that kicker making the field goal. That has nothing to do with it. So it's random stimuli in terms of whether that worked or not, and we start doing weird stuff to the point that this well-known alcohol manufacturer is making ads about it. So, summary of this phase, there's repeated intermittent stimuli with regular outcomes, enhances that learned behavior, and eventually can automate it. But the constant stable stimuli might be ignored, and random outcomes get random behavior. So variability in that intermittent stimuli is something that's going to make our behavior even more irrational. So consistent access to consistent quality product with consistent steady use may lead to decreased risk of a use disorder. Differences between the regulated or medical markets and illicit, unregulated markets can definitely be seen here. Inconsistent quality access and inconsistent use is something that definitely is part of the illicit market. Now, what about the negative reinforcement phase, the withdrawal? So the mu agonism decreases the norepinephrine tone. So norepinephrine is one of our types of adrenaline in the locus coeruleus. So this is a key part of our brain. So that consistent relaxation basically decreases those stress hormones, that adrenaline, and it decreases sympathetic tone, so things that affect our blood pressure, our heart rate. So it lowers our stress response. Now, if we keep doing that, our body is going to say, actually, we do need some stress response here. We got to be able to get through the day. So our brain adapts. We have neuroadaptation. And the locus coeruleus makes more norepinephrine to try to normalize that again. We try to get back to normal. And then, after the brain's adapted over time to this, then we take away the mu agonism, and there's nothing blocking that adrenaline that the brain's trying to overcome. And now there's way too much adrenaline, and the withdrawal of mu opioids means systemic, so all through your body, norepinephrine dysregulation. So the adrenaline is all going haywire through your whole body, and a lot of that is what the withdrawal syndrome is like. And guess what? High adrenaline also leads to very salient memories. So withdrawal is something that burns into your mind. You're going to remember what withdrawal feels like. And guess what? It's going to have an effect on that habitual behavior as well. Not just negative things, but something that's burned into your memory. So positive and negative reinforcement. So chronic use of opiates leads to that neuroadaptation, and withdrawal is kind of related to that adrenaline. And that withdrawal is a continued negative reinforcement for that continued use. So removing the withdrawal syndrome with regular access to a drug can remove that repeated negative reinforcement of withdrawal. You don't have to worry about feeling better again. You're not constantly fighting off withdrawal. So that's why medications like methadone and buprenorphine also help along those lines. They just help people feel normal, and that's what I hear a lot when I can start people on treatment, is that they finally feel normal again. So here's a bigger summary of what we just went through. So consistent access, consistent quality, and consistent steady use may lead to decreased risk of use disorder because there's less salient positive reinforcement, there's less occurrence of negative reinforcement, and less random stimuli. The pharmacology of the form and the means of administration can impact use disorder risk, so higher risk with higher potency and more rapid onset, and less risk potentially with lower potency or slower absorbed products. Finally, if we can limit the stress of the process, this is a difference between regulated and unregulated markets. So what about use disorder risk in cannabis? So legalization is not the same as regulation, nor is it the same as standardization, and that's something that we're going to talk about a little bit more, how that's a big important part if we're trying to mitigate this risk. And addiction risk perspective, from that perspective, we would say that it would be least with reliable, low-stress, consistent access to standardized products. Use of lower potency, slower onset action products would probably be preferred, at least in terms of an addiction risk scenario. But in terms of patient experience and what they need as medication, sometimes a rapid-acting product might be very important. So there are some ways to screen for cannabis as a use disorder. There are some tools like the CAUDIT SF, which asks a couple questions trying to get at those levels of dysfunction. Were you unable to stop using? Did you find that there's a lot of time spent getting, using, or recovering from it? Or did you notice kind of negative effects, so having problems with memory or conversation due to your cannabis use? And it's worth investigating more if there's greater than or equal to 2 on this score. So there's a number of different ways we can look at this in terms of the effect of cannabis on substance use and use disorders. So at the population level with opioids and medical or non-medical use, alcohol consumption, and then in the observed cannabis use and substance use disorder outcomes and some animal models. So in terms of medical marijuana laws, chronic opioid prescriptions dropped, as well as hospitalizations due to use disorders and opioid overdoses, at least in the states where this was passed. There's some more specific studies looking at groups of patients and not statewide, where we can see that if people are trying to taper off of their chronic opioid therapy, having access to cannabis correlated pretty strongly with successfully tapering off. And actually medical certification, this is a study in New Mexico, correlated pretty strongly with ceasing the opioid requirements for chronic pain. The odds ratio is about 17, which is really strong correlation there. Now, what happens in terms of medical access or legalization in terms of alcohol? So it does seem like there's an 11% decrease in traffic fatalities and about the same decrease in alcohol consumption. However, there may be an increase in binge alcohol use in heavy users. So people may be using some cannabis. So if cannabis use disorder is kind of the main thing, they're actually just going to use that, and alcohol will decrease. If you have alcohol use disorder and cannabis use disorder, you're going to use more cannabis and you're going to end up drinking more, and there's kind of more binge drinking behavior. So there can be some negative consequences in folks that have existing use disorders here. Now, there is this idea of cross-addiction, and this paper, if you're questioning the what I'm saying here, I really point you to this study here that I have cited. Cross-addiction is the history of an addiction to one drug, increasing the risk of developing an addiction to another. But what we saw is that you actually, if you had a use disorder that was treated into remission, you actually have a lower odds of developing another one. So it almost, instead of it being like, oh, you had cancer, you're therefore at higher risk of recurrence of cancer in the future, it's not actually true. It actually acts more like, well, you had chickenpox, you now have some immunity to chickenpox going into the future, and you got lower risk of that happening. It's more like immunity. So you have about a third less risk of developing another use disorder if you've already been treated for one. Now, that's successfully getting through that, and I think some of that is a heightened awareness. When people are in recovery, they're already kind of aware of, like, I really don't want to go down this road again. It was pretty rough. I don't want to go there. Now let's look at some observational viewpoints here in terms of what happens in opiate use disorder. So we see some conflicting data across multiple studies and different forms of medication-assisted treatment. So in methadone, it really seems there's some gender differences. There's it depends on heavy users or lighter users. With buprenorphine, it seems like maybe you can get by with a slightly lower dose without affecting quality of life. And then in those on long-acting injectable naltrexone, it seemed like it was actually intermittent users seemed to have better adherence to the treatment with this, not heavy users or light users. So kind of a mixed bag there. Now, with alcohol use disorder, cannabis use seems to increase the consumption if it's alcohol use disorder, plus or minus cannabis use disorder, but alcohol use would decrease if they just have cannabis use disorder and they have access to cannabis. But none of these studies provided or recommended cannabis. They're just observational. Now, in animal models, we can see that mouse genetics modulate the ability of THC to change the risk of opiate use disorder. So if we've got a setup for mice to get hooked on morphine, we can give them THC and they have a lower risk of getting hooked on morphine. Mice without opioid receptors, they lose the pain relief from THC and the reward effects, but they still have some tolerance and withdrawal. So THC does have its own unique withdrawal syndrome and some tolerance, but it decreases that reward effect. Now, THC and CBD seem to decrease opioid withdrawal in mice, but we didn't see that in rats. So probably some more to come there, but there's not really any randomized controlled trials with medical cannabis and an opiate use disorder. There may be some coming in the future, but currently we don't have great data on that specific question. Now, cannabis and alcohol use in animal models, we do have animal models of alcoholism, so we can get mice habituated to using alcohol, and if we give them naltrexone or cannabidiol and naltrexone or cannabidiol alone, we can see that naltrexone or CBD plus naltrexone, both of those setups seem to decrease how much those mice end up drinking. But cannabidiol alone doesn't seem to do that. However, once mice are in recovery, so we got them habituated, we got them kind of used to drinking a lot of alcohol, then we put them through mouse rehab, and then we expose them to alcohol again. Cannabidiol decreases the amount that they start drinking again in these mice. So there may be some benefit there, and there's actually 2 clinical trials that are going on right now looking at this question. Now, in heroin use disorder, this is a situation where these are people very early in recovery, not on any MAT. And they were basically shown pictures of their favorite way to use the drugs, so trying to cue those memories, and how much did that give you a craving? How much did that stress you out? Well, the cannabidiol actually decreased the salience of that, so it decreased the intensity of that feeling. And you can see that there's actually a dose-response curve. So the more that they took the cannabidiol, the less stressful that situation was. Even 24 hours later, that effect was still ongoing. So there's probably more to come here. It's a pretty small trial, but it is something that does seem to have a positive outcome here. So with that, I'm going to pass the baton to Gail.
Thank you. Can you hear me okay?
Yep.
Okay, so let me grab my slides. This is the part that I'm always slow at, sorry. Got it. So I'm the policy person. I'm going to take a little bit of that discussion now. And Dr. Roussel is also going to come back and join me for a few of these slides. So she really has a lot of expertise in the section on how the health facilities handle cannabis or CBD, and she's going to take a little bit of the CBD discussion, and I'll be handling some of the rest of that. So you know what, I just remembered, Jessica, we didn't take questions midway. We were kind of thinking about doing that, and we were actually going to do that right here. Do we want to take 5 minutes of questions now before we jump into the policy section or not?
I see thumbs up from Christine.
Okay.
Sure, I can relay them, and I can also watch the clock too and let you know when the 5 minutes is up.
Awesome.
One question during Dr. Roussel's presentation is, does endocannabinoid affect immunity negatively? I'm not sure if they mean endocannabinoid or if they mean cannabis.
Yeah, so I don't know, can you hear me?
Yep.
So it's another example of duality of the properties of the plant. I could talk for a whole hour on endocannabinoids and exogenous cannabinoids on immunology. So on a first level, you would call them immunomodulatory. So it makes sense that when white blood cell is trying to get another white blood cell on the bandwagon of inflammation, that there's chemicals that activate them, and there's also chemicals that inactivate them and quiet them down. And the endocannabinoids are just one of them. They also affect things like interleukins. So the full understanding is not clear, but we know that it slows the migration of white blood cells to the area. It can also affect the rate of growth of some of those cells as well. So at a low dose, I would call them immunomodulatory. I think as you get to higher doses, you might consider that they might be immunosuppressive. There are studies ranging from the use of them for anti-rejection drugs, so inhibiting the immune system so a body doesn't attack an organ that's been transplanted, to also looking at how those individual chemicals affect a patient after, say, they've had a bone marrow transplant and they have no blood cells and they have to come back up. So it's not an easy answer. You can't really say that they're immunosuppressive and are negative for the immune system, but they definitely have an effect. And the concern is that they can negate drugs. An example is a study with cancer medications. Some cancer medications work by stimulating the immune system. One study looked at immunotherapy that stimulates the immune system to fight cancer. And in the presence of cannabis use, the patients did not have as good of outcomes against fighting their cancer as in patients who did not take cannabis. So retrospective study, but it still has a lot of questions and a lot of concerns. So muddy answer. Hope that helps shed some light on that without actually giving you a definitive answer. That's what politicians do. I'm practicing.
I would just add to that. I mean, the immune system's gigantic. There's a lot of different moving pieces in it, and I would say it's immunomodulatory. I definitely agree with that description of it. I would also say we see more infections in people that are regular cannabis smokers. So in terms of lung disease, whether that's more of an effect of inhaling combusted plant material on a regular basis or directly related to the cannabis itself. I think that's something that's not really fully understood because there's not really great studies on that. But even with the CBD studies, we did see a difference, an increase in respiratory infections in the kids in some of the Epidiolex studies.
Okay, we've had a couple questions. I think probably this will be pretty straightforward for you. Folks want to understand a little bit better the prescription and access to medical cannabis. So we've got questions: if doctors can't prescribe, how does an individual obtain a medical marijuana card, and a couple different variations on that.
So a prescription would be, say, I prescribe lisinopril 10 milligram tablets, take 1 tablet daily, dispense 90 tablets. So that's what a prescription looks like. I don't prescribe, cannabis, vape, OG, Kush, 20-to-1 THC to CBD ratio, inhale twice, as needed, every 3 hours, dispense 3 vapes. I don't write anything like that. What I do is I say, you might reasonably benefit from medical cannabis, and I attest to that. At least in Pennsylvania, this is how it works. I attest to that, and then they're able to access the products at the dispensary. And a pharmacist really gets to help work with this person to determine what's going to work best for them in terms of what products might benefit them the most and help them get the results they're looking for.
Okie dokie. I think we have time for one more question then. And this is this is complex, but we've had a couple people comment on cannabis use disorder. One person said that they consider it to be more of a psychological addiction. And then a question about is it really 1 in 10 users of cannabis overall, or is it just 1 in 10 daily users or something like that develops a use disorder? So I think that speaks to your presentation, Dr. Lee. Yeah.
So the 1 in 10, it's actually about 9% in the NIDA studies looking at this. This is from the National Institute of Drug Abuse 2018 marijuana report, where it said about 9% of regular daily users would meet the criteria for cannabis use disorder. And now this is going to look different than somebody who has alcohol use disorder or cocaine use disorder. I mean, these are different substances. They're going to look different. And I think that, personally, it's not hard for me to think of people in my life that probably have an unhealthy relationship with cannabis or with alcohol. And that's something that because it looks different, I think that we're saying like, oh, it's addiction, it's use disorder, and there's a big spectrum there. It's not that somebody ends up on losing a whole lot of stuff in their life. It might be more mild, but they would meet the criteria for use disorder because it's causing some dysfunction in their life. In terms of the question of psychological versus physiological, there is a pretty defined withdrawal syndrome and that's been investigated that occurs over the first 2 weeks of ceasing use after you've been using it pretty regularly. So there is a physiological withdrawal there. I think that it's going to act different than other different drugs. People don't get cravings to smoke a joint quite as easily as cravings to smoke a cigarette, but it's going to act differently, and there is some dysfunctional behavior that can act that way. And I think that that's something that we do need to recognize, and there's good evidence for that.
Okay, that's our 5-minute mark. Do you want to move on with policy? And then I know you're planning on leaving lots of time at the end for all sorts of questions. Yes. Does that sound right? Okay.
Yeah.
Yes, we plan to leave quite a bit of time for questions. Okay, can you hear me okay?
Yep, I can hear you.
Good. There's a little bit of crackling there in the back, but I'm just really quickly going to go through the drug control policies timeline just to kind of set a framework for where we are, because I think most of you have probably heard explanations of it, but the Harrison Narcotic Act in 1914 was really a key point in terms of regulation of drugs in the United States. Then we went through alcohol prohibition, narcotics control board in the 20s. the Federal Bureau of Narcotics in the 30s, then the Marijuana Tax Act in the 30s in 1937. That was later found unconstitutional, but then the next really Substance Act in 1970, which made significant changes. That's the point where marijuana was basically being prohibited before that.
In and out a little bit, Gail?
I am? Okay. I don't know if, I apologize for that. Unfortunately, I don't have my headphones with me today. So can you hear me okay?
I think it is going in and out. I wonder if you might be able to call in.
Yes, I could do that. I'm sorry, there's a problem with audio.
Sure. While Gail's calling in, I can talk for a minute. Does that sound good, Gail?
Okay, well,
so just looking at the timeline, I think the Marijuana Tax Act is very interesting. So when you look at the Harrison Narcotic Act of 1906, they didn't include cannabis. They didn't look at it as a narcotic. They were really focused on things like cocaine and opioids. And then, there was alcohol prohibition, and with that, tens of thousands, I think it was 30,000 maybe law enforcement officers working on alcohol prohibition. And when alcohol prohibition ended, some people might think that they needed jobs, and and cannabis might have been a good target. The Marijuana Tax Act was actually opposed by the American Medical Association because it required just a lengthy, heavy burden on the prescribers to be able to give cannabis to their patients, and the fines were significant. Gail, whenever you're good, you can jump back into your lovely material.
I'm still calling in, so you go ahead.
Okay. And so ultimately it was found unconstitutional, and it was replaced by what we have now, which is the Controlled Substance Act. And that's what has different schedules of medications, schedules 1 through 5, with Schedule 1 drugs being those that are federally illegal. So cannabis is listed with medications like LSD. One thing that's interesting is there have been some stages along that process. The Federal Compassionate Use Program allowed patients to apply for access to cannabis. And again, 13 people were allowed into that program. And then when the HIV crisis blew up and so many patients were applying, the government shut it down because they had over 200 applicants and they felt that they couldn't process them. And the can that we showed in the beginning was one gentleman who still over 30 years, 300 marijuana cigarettes every single month. So we're going to states, and that's where the next level of legalization comes forth. And then we'll talk about the Farm Bill, and then we'll also do a timeline just specifically on cannabidiol. Gail, if you could switch to the next slide, and unless you're ready to go. If you look at the state policies, California was the first one with medical cannabis regulation. But every state is different, which is very problematic. One question was, how do my patients get access? Well, it really depends on where you're located. And there's a heterogeneity of programs and such that California, for example, allows for self-cultivation. So patients can grow it themselves. There are dispensaries where you have states like Pennsylvania, Connecticut, Minnesota, where it's grown by facilities and a patient can go to a dispensary, but a licensed pharmacist has to be there to give the patient their cannabis and help guide what is an appropriate therapeutic amount and dose. And even amongst those, states like Connecticut or Minnesota, the pharmacist decides exactly how much a patient can get access to. In Pennsylvania, unfortunately, there is a pharmacist in the dispensary, but the patient by law is allowed to purchase as much of any product that they want, unless there was some type of limitation by their physician. And even with that, there are flaws. In the Pennsylvania system, the program was live for over a year before the pharmacist at the dispensary could see the prohibition that the doctor said. Please don't give my patient raw flower to smoke. Not seen, so allowed to be sold to a patient for over a year, for example. And Gail, if you're ready, go for it.
Yeah, Jessica, can you mute me through the internet? Because I am not, able to hear you right now. Can you hear me through the phone?
Yeah, we can hear you.
For some reason, I can't hear you. So I'll go move forward, and Chris and Dr. Roussel, I'll let you know when it's time for your audio to kick in. We just briefly want to discuss the limitations on federal action. The Attorney General has several times over the years issued statements regarding why the federal government is not going to enforce the fact that cannabis is Schedule I as under the Controlled Substances Act. So, you know, this is still confusing sometimes because we know that the federal government could, and under different administrations has talked about restricting states that are breaking the rules in terms of violating the Controlled Substances Act, which is 33 states right now, as you saw on that last slide. But one of the reasons they haven't been able to do it is that each year the US Congress uses appropriations to restrict the Department of Justice ability to do this. And each year those have passed as amendments on the appropriations bills. So unfortunately, the Department of Justice cannot use federal funds to interfere with state medical cannabis laws under those amendments. However, that's just medical cannabis. So there are opportunities for them to interfere in the case of recreational or adult use cannabis. One thing that Dr. Roussel is going to talk a little bit about is the cannabidiol, the CBD policies, because we find people are really confused about those when you're walking into stores and you're seeing CBD being sold when at the same time cannabidiol is not legal in general, particularly crossing state lines. So Dr. Roussel will refute some of that. The 2018 Farm Bill, as you saw on that timeline, was really key in terms of removing hemp from the Controlled Substances Act. However, cannabidiol is not from cannabis, is still part of, under the supervision of the Food, Drug, and Cosmetics Act. So the FDA still has the ability to regulate that, and we've really seen a step up in enforcement of CBD products in food or in cosmetics or in several, or as basically being promoted as a drug. And the CBD enforcement from the FDA has really been stepped up recently from what we've seen. Dr. Roussel, why don't you talk a little bit more about this section?
Sure. So I like to kind of start with the beginning with it. And people will talk about the Agricultural Act, or they call it the Farm Bill from 2014. And in it, it allowed for CBD products and hemp, basically hemp, to be produced under state research opportunities. So it wasn't allowed to cross state lines. And with hemp became the hemp extracts. And unfortunately, they started to be found everywhere in the United States. So the DEA cracked down pretty early and said, hey, listen, any extract of the marijuana plant, so that's hemp or cannabis or marijuana, it's all the same, is federally illegal. And they also clarified that any extract of cannabis, even if you aim for pure CBD, will have other amounts of cannabinoids in them just by nature of the plant. And even chemistry-wise, it's very difficult to separate out all those chemicals to get a pure CBD product. Now, so that was 2014-15. Battle still rages. But then FDA approved Epidiolex, which is a pure CBD product, 98% CBD, meant for children with seizure disorders. And the FDA approved it, and then the DEA had to figure out how to schedule it. And they sat on it for a few months and came out with, okay, it is approved, but it's Schedule 5. And there's certain narcotic cough syrups that are Schedule 5, certain drugs like benzodiazepines, Schedule 5. So they allowed for it, but the DEA made clear only CBD products that are FDA approved are acceptable. And FDA claimed ownership. They said clearly, anything that's produced for human consumption, whether it's a food or a drug, is under the ownership of the FDA. And now you have the Agricultural Improvement Act of 2018. It's a 300-page document. At the end, there are 3 sentences. It's like the second to last page that says hemp is removed from the Controlled Substance Act and can be grown as a crop. But what they don't tell you is that the front of the 300 pages is that the FDA controls everything that's agricultural because it's meant for consumption. So they make it clear you can't put it in food because there is a controlled product. Gail, could you flip to the next slide? You can't put THC in food and you can't put CBD in food. They're not considered dietary supplements. But there's other statements from the FDA, some that even came out in March, that said we're interested and we're doing research on the topic. The FDA-approved CBD product in children has a black box warning for damage to the liver. And so FDA has been working with a lot of producers of CBD products to do some research. This is a non-proprietary talk, but there's definitely some bigger names in CBD production that are even shipping internationally. So it's an interesting regulatory situation where the FDA does cite certain CBD manufacturers with a focus on any making false claims. They cite facilities that are gas stations and other places selling, but they are allowing sales from large companies through certain supply chains. Next slide. But this opened us up to a big problem. So if they're not actually regulated by the FDA, because the FDA has control, but they never wrote the rule book. So until the FDA writes regulations and standards, there's nothing controlling the products that are produced by the industry. So when you look, there's a couple studies that looked at CBD products and what's in them. And they found almost half have way more drug on the label, in the bottle, than is on the label. So about less than a third of the products actually had the amount that was written on the bottle. They've had ones that have been pulled from the market for things like high lead content. So nobody's checking them for pesticides or heavy metals or leftover hydrocarbons like butane, unfortunately. And then in samples, and this has been repeating in more than one study, about a quarter, 1 in 5 of these products have THC in it. Some that are contaminated with THC so much, such as 6 milligrams per milliliter, that, you know, 1 milliliter would be enough to get myself impaired to a recreational level. So whether that's intentional or not. CBD offers benefits to certain patients, so it's important to use CBD from a reputable source. Ask for a certificate of analysis in those products, and that's really important. Next slide. From healthcare facilities-wise, do you let your patients use cannabis or CBD products? How do you manage that? So whether it's cannabis or CBD, because CBD is a cannabis product, they're not FDA approved, and they're not regulated. If a physician can't prescribe it, and a facility can't purchase it and give it to their patients, so what do? You know, so I'm a director of pharmacy at an inpatient facility, and we have pediatric patients. We've had pediatric patients wanting to bring in their cannabis for, at this point, about 4 years now. So starting with them, we had to figure out a policy. What were we going to do? We could say no cannabis products at all. We could allow cannabis products, or we could say yes, but with a lot of restrictions. And that's what we do because there are cancer patients and other considerations where we want to do that. Next slide. So there are a few steps with the provider. So firstly, we just need to make sure that you need to know what form a patient is taking. At our facility, we don't allow inhalation products. We don't allow patients to access cannabis unless they have a licensed card, so they're approved by the state, and we make sure we only allow products that have been from approved dispensaries. Next slide. If the patients can't follow that criteria, we don't get to move forward. And then also we look at adverse effects and other considerations. In our institution, it's not a treatment facility, but if a patient's impaired or had a fall, would be appropriate. Patients with psychosis issues, cardiac issues. Next slide, please. All considerations for that. And if a physician does want to allow a patient to continue, it really is important for the wording to be understood. This doctor who oversees your facility is going to allow a patient to take their own product. They're going to allow them to continue therapy that was initiated by another prescriber. Similarly, think about cholesterol medication. If you're in a hospital for pneumonia, you know, when you come in the door, that doctor may write for your cholesterol medication, but they weren't the ones who started it. But they may continue it because they don't see a reason to stop it. It becomes a similar discussion, but there's more complex issues. Chain of custody, patient responsibility for the product. And with regards to cannabis, if you have patients who are already predisposed to issues relating to management of substances, do you allow them to self-administer? Do you control the dose? Next slide, please. And that's really important. That dose is critical. You have to document their responsibilities. That patient needs to know what are the limits and what's acceptable. You have to define that. And in our facility, we get it written. We have it in writing. And we also make it clear that it's not our responsibility to safeguard their products. Next slide. Next slide, please. Further, what's in that product? What are they actually taking is important. Maybe it's appropriate for your patients to have CBD, but it's not appropriate for them to have THC. Would you know the difference from the package? Just looking at these packages, this product says CBD capsules, which is great, and you would think that that might be acceptable. But if you read the fine print, every capsule has 5 milligrams of CBD and 5 milligrams of THC. So 5 milligrams of CBD is likely not enough drug therapeutically, not going to have the effects you want. And 5 milligrams of THC is plenty enough to get somebody intoxicated. So though it says CBD, it's not the most appropriate choice for your patients. There are patches, there are other agents. This product says 4 to 1. Is it THC first or CBD first? What is there more of? So there's a lot of issues with labeling, and we need more regulation around the labeling so we can move forward with patient care. Next slide, please. Because ultimately you want to be able to say, where'd you get it from, and how much are you really taking? So while cannabis may be a therapeutic option for patients struggling with other medical conditions, we need to make sure that it's more clear that we're using it as a medicine with a specific dose, a low dose, starting low, going slow, being appropriate in a therapeutic realm. Next slide, please. Gail, back to you.
I apologize for the technical difficulties there, and hopefully you can hear me. If not, Jessica, let me know. One of the things we wanted to talk about is the controversies around the legalization of cannabis a little bit and the policy opportunities there. And, you know, we have to start with the dramatic change in U.S. public opinion around legalization of cannabis. As you may have seen the research that Pew Research does every year. And every year we put a new slide in our presentation, and each time the support has gone up. Every year it's increased by a few percentage. So again, it's at a record level right now in terms of people believing that cannabis should be made legal or not. They do differ in whether they want it, whether they approve of it for therapeutic or for adult use. I do want to talk about what some of the key controversies that concern people in terms of legalization or decriminalization. One of them is driving. Dr. Lake talked a little bit about this, and I just want to caution from a policy point of view. We know this is one of the major comments that people make when they're reluctant to be supportive of policies around cannabis decriminalization or legalization. It's what are we going to do about driving? The problem is that the studies we have do not control for alcohol well. And the bottom line is we know cannabis does impair driving, but we don't know what the level of THC means in terms of impairment. And we know that if the studies control for alcohol, many of the studies that show an increased crash risk in states that have that have legalized cannabis and have a lot of citizens using cannabis do not see significance. So, you know, we also have a lot of problems with data in those research. So, you know, unfortunately, we do not have a reliable measure of impairment, and we do not have studies that show when they control for drivers' age, gender, race, and alcohol, that states that have liberalized the access to cannabis have seen major issues in terms of increased crashes. Another issue Dr. Roussel talked about and Dr. Lake talked about is adolescent cannabis use. It's definitely increased, so we're just going to move forward with this. However, it was pretty stable until 2015. So it's just the last few years that we've seen some increases in the Monitoring the Future survey and other surveys of adolescents. So I would caution you that we really don't know to what extent the cannabis increase in adolescence in terms of increased use is part of more comfort level with reporting. And we don't know how much of that is risky or problematic use. On the whole, it was very stable until just the last couple of years we started to see some increases. Again, in terms of percent of use of students reporting marijuana, I think most of you are familiar with this data. So we want to move on so we have time to get to your questions. If you want to revisit this, we can. One thing that Dr. Roussel pointed out earlier in some of her discussion of cognitive function, and we'll just mention here as well, is that in the studies around cognitive function, after 72 hours of abstinence, function has returned to normal. In fact, Dr. Roussel, why don't you take this slide? This is really an area that you've done a lot of study, and I think if people have questions later about this, I'd like you to kind of chime in if you could.
Sure. Can you just flip to the slide before, if that's okay? There are different domains to look at cognitive function and to assess a patient on. And one of the big things with cannabis is effects to verbal and visual learning. So just orienting yourself to the graph, there's a dotted line that goes down the middle where the 0 is, and that means that there's no change in effect with cannabis. And then the further the line is to the left, the worse the effects were. So when you look, cannabis does affect learning, abstract thought, how fast you're processing information, and your memory process. So it does have negative effects, but the big thing is they were not permanent. Go to the next slide, please, Gail. So if you look, there's a couple different things. Within 72 hours, those patients were able to go back to normal cognitive function. But I have to say, motor function wasn't significantly changed, but put it in perspective. Patients who use benzodiazepines chronically, for example, they actually have delayed motor function. There are studies showing people with chronic benzodiazepines have a longer time putting pegs into the holes of like a wooden block. And then you wait and ask them to stop taking those drugs and come back 3 days later, and they're able to do that same motor function task but with greater speed. So these are things that we do expect from certain medications. For adolescent cannabis users, there's conflicting information. So there's the New Zealand study. So I think it depends on what you're citing for maybe what you're trying to get across. The New Zealand study talked about declines in IQ. They had ones about verbal and visual learning and having those effects be persistent. But there were also people who are persistent users. So that becomes a more question. A lot of the studies have had a lot of co-founders that really affected their ability to properly assess and find out what that individual issue that's causing. There are many familial factors. Patients don't use a chronic illicit substance in a vacuum. There are other things going on with them. Another study, actually a few, 3, showing no evidence of long-term cognitive effects. So it really depends on what study you look at, and it's not clear. More information is needed. That's kind of the ultimate takeaway for that. However, I think that there's more studies that are in favor of no residual cognitive effects when you weigh them out together. Gail?
Thanks, Dr. Roussel. Yes, very similar to our discussion about how cannabis legalization will impact the opioid crisis. Part of the issue is that we have a variety of studies, and it's the difference that each of us has talked about today, the difference between correlation and causation when you look at population level. I just want to mention that we do have research that you can cite, and you have the citations in these slides. And if you want to ask us questions about it, we can talk about them. But there's a couple reasons why people believe that cannabis legalization may positively or negatively impact the opioid crisis. One is primarily gateway theory to opioids, people moving from cannabis to opioids and presumably to problem use, on overdose deaths, and potential for opioid substitution positively or negatively. Again, the studies that we have, it's really challenging to control all the different kinds of outcome measures that really needed to be controlled for. I will say that in terms of the gateway theory to opioids, I'm often kind of explaining this to people who are just that cannabis use leads to problematic use of other drugs. And the CDC says that the gateway theory has not been proven. The majority of people who use cannabis don't go on to use other substances. And there's a lot of other resources for you in terms of having this discussion with your patients or with your family members or your peers. In general, we know that because people who have used other drugs are more likely to use cannabis, that's the direction it may be. This was a key study in 2017 about whether medical marijuana laws reduced addiction and death related to opioids. It caused quite a splash. Dr. Powell, Dr. Pecula, and Dr. Jacobson have also gone on to do a number of other studies. Bottom line is they did see positive effects. They saw that legally protected and operating medical marijuana dispensaries did reduce opioid-related harms in states that had those medical marijuana laws. They did see a decline in opioid overdose deaths and a decline in the rate that people sought treatment. Treatment admissions were down and overdose death rates down in states with dispensaries. However, they were really clear that this is not a solution to the opioid crisis to legalize cannabis. And then some of the other studies that we looked at found that with different data, we didn't see some of the same effects. Again, several of the same authors did this later study, which was also one that showed evidence that medical cannabis laws were associated with reductions in mortality. But I want to refer you to this study. What I like about this one, Dr. Chihuri and Lee, this was just published last fall. They looked at all of these other studies and really some of the correlations. They found of the 7 studies with the association between medical marijuana laws and opioid prescriptions, 4 saw a decline in prescription opioids, several were not statistically different, and 1 found a non-significant increase. And of the studies looking at opioid prescribing, 4 saw an association between the medical marijuana laws and opioid overdose prescribing. However, several found reductions, again, that were not statistically significant. So if you look at the little forest plots there and here and see from decreased rate of mortality to increased rate of mortality in some of these significant studies compared to a random effects model for mortality and then also for opioid prescribing, we really can't draw a strong conclusion. It seems to be leaning in the direction of a more positive effect if you look at decreased rate of prescriptions as being a positive effect. But there's in terms of the confidence interval, it's not always significant. So that's the data, folks. What I do want to talk about what we know doesn't work in terms of drug policy. And one of them, the things that we know doesn't work is supply side controls. We can certainly reduce drug use if we increase prices significantly. But over time, that doesn't work because people continue to use drugs and they always have. One thing that we know doesn't work, and the data is really clear on this, is wide-scale arrests, incarceration, the war on drugs. It's not been effective globally. It's not effective in the United States. And of course, we also find that some things we try for drug use prevention aren't effective either. So we have a lot to discuss in terms of policies. We do know that there are some very effective psychosocial developmental interventions for prevention. Some of you work in prevention, so I don't want to imply that we don't have things that work. But just say no And scare campaigns don't work. One thing that I want to leave you with as a resource that I found really helpful, if you saw this back in 2016, this was an extensive study that did mathematical modeling. They looked at public health all over the world, this Lancet Johns Hopkins University Commission, to say what would be an evidence-based approach to drug policy. And I just want to leave this with you in terms of, how do we think we're going to deal with the potential for harms or benefits in terms of legalization of cannabis, because public widely supports it. We're moving in that direction. And when we look at drug policy as a whole, it's really clear that decriminalizing nonviolent use, eliminating police violence and carceral harms is a positive public health evidence-based approach. And so, there's a lot we have to do in terms of regulation, and I'm a big supporter of regulation. I think that the evidence supports it. I think that's the direction we're probably heading in the United States. So the question is really, as you heard from Dr. Roussel and also from some of the information Dr. Lake shared, how do we do it in a way that will be safe is a big concern. We're about to go to questions, and we just want to let you know that if you're a healthcare provider that needs a more extensive clinical training, University of the Sciences is one of a number of providers in Pennsylvania, the only one that does live classes regularly and has always done some live classes online, that can provide a certification and CME for physicians and CE for pharmacists. So in Pennsylvania, this is approved by the Department of Health for those of you who live in Pennsylvania and are potentially able to make a recommendation for cannabis. This is a course you can take. So here's where,
and it's also helpful. I was going to say, for the 4-hour class, we get a lot of other people who are not interested in working in the state program, but just want more information from a different perspective and something that's a little bit more in depth. Also joining that class, we have a dispensary pharmacist who participates in it as well, to provide some more patient-focused recommendations and case studies.
All right.
All right, thank you all. As you can imagine, we've gotten a number of questions submitted, and I'm trying to, hopefully, even if I don't get to your specific question, which I think is impossible to get to all of them, I'll try to group them so that I touch on a lot of the different issues that people are interested in. And one of the ones that has come in different variations on is people have questions about the impact of marijuana use on adolescent brain development. So it seems that that was not something that you necessarily talked about in reviewing the research on. So could you talk about that?
Dr. Lake, do you want to take a shot? I did say a lot of what my perspective was.
Yeah, I mean, it's a big topic. I would start by saying that in pregnancy and in children, or really just minors, I mean, that's how we're defining it, the impacts on anything were much more conservative, whereas adults, I mean, we're, as a culture, we're kind of like, well, you're an adult, you can figure it out. So when something is affecting children, that tends to kind of like pull on our heartstrings a little bit more. Now, in terms of does it affect brain development, I would say yes, in the sense that it's affecting, it's having profound experiences and everything. If you're using something on a regular basis, it is going to be kind of guiding something in a certain way. I wouldn't frame it in the same sense as like, oh, something's forever broken because you smoked a lot of weed in high school. Like, that's not kind of how we understand it. The brain retains a good bit of plasticity over time and can adapt to lots of different things. But I would say that there's probably some critical developmental periods where you might be getting shortchanged a little bit if you spend the entire time under the influence of cannabis in a way that you're kind of using that as your main coping mechanism for dealing with stressful things in life, similar to other ways that might be maladaptive. But very hard to say, okay, if we're giving this in a controlled manner like any other medication, is it super harmful? What we really have is people using it kind of in the illicit market, not as something that's kind of being recommended and kind of looking at that outcome, which is different.
Great. Oh, sorry.
It was a study from Children's Hospital of Philadelphia, and they used a cohort of adolescents they had been following basically from birth till about 21 years old. And they asked them to report on things such as cannabis use and how frequently. And they broke them into 3 groups: non-cannabis users, those who use cannabis less than 3 times per week, and those who use cannabis more than 3 times per week. And then from that, they looked at cognitive function, and they found that things that had a greater negative effect were earlier use in terms of age, such as like 10, 12 years old had more of a negative impact on cognitive function, and then more frequent use. So those who use cannabis more than 3 times per week had poorer cognitive function, visual and verbal learning compared to non-cannabis users. What was interesting was the kids and adolescents who used cannabis 3 times or less per week actually had normal cognitive function, and in some aspects had some higher emotional intelligence and some other aspects. So one could kind of pull from that children who might have been possibly more mature at baseline were better able to have moderate use of the product. But what they did show was there are time windows. So the earlier you use it, the greater the cognitive function. But even in those patients, especially 15, 16 years old, but by the time they got to 18, regardless of how much they used, their cognitive function had returned to normal. So there's a lot of factors, when you start using, how much you're using, and how much cumulatively, but it doesn't have the negative effects that we thought. Again, that's one study. That study had trouble getting published. So they did a large meta-analysis looking at cognitive dysfunction in adolescents, and they were able to show a similar trend amongst that meta-analysis, which helped them finally get their paper published because it had so many rejections. So check out, again, I mentioned him, Dr. Cobb-Scott, worth reading about cognitive dysfunction in adolescents if you want to know more. 50 pages altogether. Enjoy.
We have some questions about child welfare agencies. I'm going to mute you, Christine, when you're not talking because I just get a little feedback. It says when child welfare agencies are looking at medical marijuana use among their patients and toxicology screens indicate high levels of THC, such as over 900 milligrams. I'm not sure what units they're using. Does this provide any insight into their parenting abilities? And then another question more broadly about how can providers educate and report medical marijuana use for parents involved with state child welfare agencies where medical marijuana is legal so that they can help parents with reunification? This may not be inside your wheelhouse, but obviously it's like very relevant for any parents that are involved in the welfare system.
So, I mean, I would say in terms of medical cannabis use, trying to, especially in parents, I mean, it's something where you're going to want to make sure that they have adequate safety considerations in terms of storage, not making it into edibles. It's, that concern of children taking edibles by accident or accidentally on purpose. That's one of the reasons why in Pennsylvania edibles aren't allowed. But people can still make them after it leaves the dispensary. Humans do human stuff. So making sure that they're keeping it safe. In terms of a safe level or commenting on their ability to parent, that's something that is a much more functional assessment that's really challenging to make off of a level on a test. The other thing about urine drug testing is that THC or the hydroxy component that's tested for is something that sticks around a really long time, so it can build up a lot over time. So if you have a very reasonable kind of low-level amount that you're using on a regular basis, you're going to continue to test positive for a long time even after you stop using. So the actual impairment is something that's going to be much more acute compared to how long you'll test positive. Also, just in terms of urine drug testing, you really need to standardize it for concentration. So with creatinine, there's a lot more things, just because if your urine's more concentrated, then that number is going to look really high. Whereas if you're very well hydrated, it might look lower. So trying to trend that or something is something that gets very challenging, and I've had to do it for some very specific situations, but it gets very cumbersome. It's not very clear cut when it comes to that.
So 2 examples. So the American Industrial Hygiene Association has long been working on a cannabis medical surveillance policy. So recommendations about what jobs can people do and use medical cannabis. And they've been debating that for, I guess it's going on 3 years now, without consensus. For perspective. And so it really comes down to functional assessments. It's the same thing in employment. If somebody's taking opioids daily in the in the workplace, well, you may not notice, or you may notice and there's an issue. Is somebody taking a daily benzodiazepine, Klonopin, and it helps them with their anxiety and they can function at work, or do they have slurred speech and slow motor reflexes? I can only speak to that because my heart goes out to social workers, because that's way more intense decisions that I would have to consider. But certainly safety in the home and safety while driving are the top things that come to mind with regards to that. And to be honest with you, I was asked to actually testify in a legal case related to that, trying to take custody away from a parent. And I declined because personally I don't think that there's strong enough scientific information to argue that, unfortunately. That was just my thing. I like to mind my own business as well.
Thank you. This person asks, are there any resources that keep track of independent testing done on CBD products so that we can better educate ourselves and our patients?
That's Christine.
Yeah, no, there needs to be a central database. But what you can do is, if you go to the FDA website, the FDA has been citing many companies for having CBD products with no CBD in them, or having from ones with THC in them. So at least you can go online and have a list of the ones that you don't want. And then I also recommend calling the company. I've had situations, unfortunately, I had a patient who tested positive on a urine drug screen, and she had been using CBD products and not THC. So we tried to call the company, weren't able to get to a human being, and it was a shell company. So I think the first things you want to think about is the company reputable? Do they have people who really work there? Can you access them? And then you want to ask for a certificate of analysis. But I think it would be a great idea to have a website where people put all that data together. If it was not something that was continuing education and unbiased, I'd tell you my real opinion of some of the companies. But yeah, so ask for information. See if they can actually give it to you, and if there's a knowledgeable person there. That's a good start. Check FDA.
And there's a number that got pulled because of lead contamination too. So there's not just the CBD, THC concentrations, but contaminants, which makes me more grateful for kind of Pennsylvania standards.
Yeah, University of the Sciences has.
I suggest you not get a company that sells that flavor. Hint, hint.
Okay. University of the Sciences has been very involved in. Dr. Roussel has donated a lot of. Be a part of discussions of labeling and standards. We don't have good national standards yet, and that's certainly the direction the FDA is going. I just wanted to mention that in Pennsylvania recently, the Department of Health has been citing food products. So, we're starting to see more enforcement, but we don't see the kind of standards that would make it easier for you to make recommendations about whether an over-the-counter CBD product.
Okay.
Yeah, just and piggybacking on that, there's 2 groups. ASTM is the American Standards and Testing Materials, and they write everything from hard hats to rubber gloves. And they have a lot of different standards in place for cannabis that they're working towards, including everything from contamination to proper labeling. So that's something that's not available yet, but something to look forward to in the future. And then the U.S. Pharmacopoeia, which creates monographs for every drug that you see that's FDA approved, even some select dietary supplements. They've been working on that since 2016. There's a secret draft that's going around, but there's still, I spoke to the USP this morning, there's still, at least a year away due to the amount of debates, because there's so many different chemicals in a plant. The tomatoes I grow in my yard are not going to taste like the tomatoes that grow in somebody else's yard. So that heterogeneity makes the analytical testing and consistency extremely difficult. And I'll stop talking about this topic immediately.
So I think we only have time for one more question, and that's just not going to be I wish we could answer all of these questions, but we've had a couple questions about marijuana and anxiety, and I know that's probably, that's like a big topic. And so there's questions about anxious adolescents and anxious adults, and so I wonder if you would maybe speak to both of those questions.
Yes, I can start with this one. So from my read on the data, it looks somewhat similar to what we see with alcohol use and when we're talking about PTSD and anxiety. So whether it's alcohol or cannabis or benzodiazepines, there is a stabilizing sort of effect that we get where people can get some benefits or some utility to that. It is something where you kind of end up kind of with this up and down, and that tends to be kind of where the modulation is coming from of the stressful situations is kind of an external factor, and you do want to try to build up this internal sort of ability to modulate that stress and that anxiety. So sometimes having things like benzodiazepines or cannabis or alcohol can make it harder to engage in those processes and trying to regulate the anxiety. It's something that that certainly, when it comes to how easy is it to stop using them, I mean, benzodiazepines are very hard to stop in terms of their withdrawal syndrome is pretty rough, especially compared to cannabis. So, you know, it wouldn't be my first stop in terms of something to recommend, but certainly it would have some functional use there. It would not be kind of the only thing that I would be recommending in terms of somebody's managing their anxiety or their PTSD, but it may be fitting kind of a part of the therapy, especially if it allows them to kind of engage with counseling or some of the things to try to work on the software kind of end of things. When it comes to kind of managing some of these mental health conditions.
Anybody else have anything to add about that? Or actually, even more, since we are going to wind up in a couple of minutes, if you have any final thoughts or ways you want to wrap up the whole topic, that would be great too.
So just my perspectives on it, whether it's anxiety or other uses, the dose makes the poison. Again, I have a degree in toxicology, so everything has a threshold, and there are different levels of effects based on dose. And I think when you talk about cannabis, a tincture product, where you're talking about, you know, a half a milliliter or a quarter of a milliliter, 1 milligram twice a day, that's a different safety profile than when you're talking about 10 milligrams a day of THC, and that really is the issue. It's not just do you use the product or not, it's really how you use it, and do you use it as a consistent dose and controlled, and that's really the scope of everything. And again, the side effects are going to change based on that dose, so really having an appropriate plan, and if you're going to use it, treating it like a regular medication. Before you initiate a drug, there's a risk versus benefit consideration, and then you have goals of why you use a drug. And if you don't achieve the goals that you set forth with that medication, then you stop using that medication. So that's my perspective on cannabis.
Yeah, I think kind of looking at it from a scientific perspective, it's frustrating to try to talk about medical cannabis and most of the research is being done on the illicit cannabis market or somebody using it without any sort of medical recommendations or without a specific guided intent for that. So it kind of feels like we're talking about two different things. It's almost like I'm trying to understand how morphine might work by studying injection heroin use. Like these are, that's not the most apt comparison, but it's something where it's like, they're very different subjects, and when we have something that's regulated and refined and you have a consistent product that you can count on with regular access and you're using it with some intention, I think that we're going to see a different risk profile emerge, and I think that it's something that is going to be have a lot more favorable risk-benefit to it. And if we're simply thinking about the illicit use or recreational use, It's something that looks a little bit different, but again, needs to be compared to something like alcohol and not something like orange juice. You know, it needs to be compared to something similar.
Thank you very much.
I agree. I have nothing to add.
Well, wonderful. We're getting people are thanking us and thanking you really for the webinar and saying that it helps them help answer some questions and encourage further learning, which I think is all that one could hope to do in 2 hours on this topic. So thank you again so much for your time and expertise. And questions that people always have is whether this webinar will be available on demand if they missed some or all of it. And the answer is yes, we are recording this webinar and we'll post it. Someone just said another 2 hours would be great, but I'm guessing that you guys don't have to. I can't do that.
That's why we have that class.
We have a 4-hour class we usually do, right? Dr. Roussel and I, you can see us again.
Some of the same slides, but no.
Some of the same slides, yeah.
And so you can watch this webinar again. You can attend that 4-hour class if you have more specific questions, and I'm sure that everyone does have lots of specific questions, especially since so many people are direct service providers in the behavioral health field. The slides will also be posted, so there's a lot of data and a lot of information you could even get from flipping through the slides again. And then if you don't mind, Gail, I'm going to take the, let's see, I'm going to take the hosting, presenting privileges from you, and just share my screen so people can see a little bit more information about CEUs, because they always want to know about that as well. So let's see, here we go. So just to review, what's that? From current slide. Okay. So for those of you who want CEUs or a certificate of attendance, the way you're going to do that is by going into your account on our website, and you'll click on the name of this presentation. This says SBIRT 101, but in this case it will say the name of this webinar. You'll scroll to the bottom of the page, and then you'll be able to access your CEUs or your certificate of completion. If you don't see it immediately, that's by design. It takes us 48 hours to cross-check your participation. So if you don't see it, you can email us, but we won't get back to you for another 2 days because we're waiting for that process to take place. So please be patient. We appreciate it. Yeah, you'll see an option to download the certificate, and you'll have it instantly. So you're not getting anything in the mail. This is going to download onto your computer, and you can print it or email it or just keep it in your file. Finally, please stay in touch with us if you want more information about cannabis or about any number of issues related to addiction and addiction treatment. You can subscribe to our newsletters to get information about upcoming training, or connect with us on social media. So again, I want to thank you, Adam, Christine, and Gail, for your presentation, and thank you all. There was about 300 participants, and we really appreciate you taking the time to come to this. Any questions, shoot us an email, info@ireta.org. And with that, I will conclude the webinar. Thank you all so much. Have a great evening.
Thanks, everybody.
Thanks.